and ensure that all electronic devices have been turned to off or silent. Thank you for your cooperation. Our program is about to begin. Ladies and gentlemen, please welcome once again your MC, Kadest Tesfagiorgis.
Good morning, everybody. Welcome to day 2, our second plenary. I hope yesterday was productive and thought-provoking. I hope you were able to go enjoy the African American National Museum. How about a round of applause for the team who organized that? Thank you. So 3 years ago, we met in Seattle. It was in the middle of the Ebola epidemic. We had a special panel discussion to help the audience understand the crisis. Since then, Ebola has been brought under control in West Africa and again in the DRC just a few months ago, and then Zika has popped up. As Tony Fauci told us yesterday, being creative about developing vaccines to protect us from these emerging threats is absolutely critical. Now, I have the honor of introducing 3 speakers who together are going to tell us and show us what the future of vaccine discovery looks like. What you're about to see is simply really cool. I'm quite excited and very thrilled to welcome to the stage Barney Graham, Megan McCarthy, and Phil Cruz, all of the National Institutes of Allergy and Infectious Diseases. Thank you.
Well, thank you, Kadest, and thank you to the Gates Foundation and to the organizers for giving us this opportunity to describe our thoughts and images about how to deal with pandemic disease, preparing for pandemic disease. We're going to get to, at the end, virtual reality of molecules to help us design vaccines, but to get into that, I just want to show who I work with every day at the Vaccine Research Center on the NIH campus in NIAID. We're in Building 40, and these are the principal investigators that are responsible for a lot of this work. We're constantly faced with emerging viral diseases, and they've been particularly prominent over the last 4 or 5 years. And there's many reasons, and the meeting's about what we're going to do about these threats, but it's clear that traditional public health measures are not sufficient. They sometimes work, but they're not sufficient either to manage the existing threats or to prepare for the new emerging infections coming. So the question is, can we use our new technologies to turn antiviral vaccine development into an engineering exercise? And today, I hope that you will at least leave with the unified thought that structural biology is going to be a key component of understanding how to deal with these new infections. I'm just going to give you a couple of examples of how we've used this at the VRC, and then get into the demonstration. I'm going to briefly review structure-guided design of an RSV vaccine, how that's been applied to coronaviruses, and then how we're using structure to solve the problem of making a universal influenza vaccine. RSV is a disease that infects and causes problems at the extremes of age. It's the peak age of hospitalization is about 2 to 3 months of age. It's a leading cause of hospitalization in children under 5, and it causes about 118,000 deaths in young infants every year throughout the world. It's a pneumovirus. It's an orthopneumovirus in the family Pneumoviridae, and I'm showing you a cartoon of the virus in the middle. We're going to talk about the fusion protein today, the F glycoprotein. We know that on the virus surface, F exists in 2 different forms. It's a short form and a long form, and recently these structures have been solved at the atomic level, and so we know that the shorter form corresponds to the pre-fusion molecule, the functional molecule, the one that's triggered to rearrange and become and turn into that post-fusion molecule at the bottom. it's important to understand the difference between these two molecules, because I'm showing you here an epitope map that we've been able to construct with all the hundreds of new antibodies that are available, showing that some of the epitopes and the major targets for neutralizing antibody are that red and orange patch at the top, and those don't exist on the post-fusion F molecule. We've been using the post-fusion F molecule for the last 40 years. There's been a number of failed vaccine efforts, and we think that being able to now to define the key target for neutralization on the virus will make a difference in vaccine development, because there is a hierarchy of neutralization potency, and all the good ones are on the top, and those are lost during the rearrangement. And so solving that pre-fusion structure of F allowed us to stabilize that molecule with the trimerization domain at the C terminus and holding it together with a few mutations in the middle that are shown there. And when you use those proteins in an animal experiment, you can show that the immunogenicity is about 70 to 80 times better than you can get with the post-fusion molecule. So solving that structure, defining the structure, stabilizing the structure, has led to a new vaccine candidate, and it's now in a vial. The study's underway. We just enrolled the 40th subject, and those results will be presented later in December. RSV-F is one of a group of class 1 fusion proteins that many of the viruses use that we work on. Ebola, influenza, HIV, and coronavirus all have class 1 fusion proteins that have a few shared set of characteristics, primarily that they're cleaved in the middle, exposing a hydrophobic fusion peptide, and those then, the heptad repeats in the right-hand side of that molecule are attracted to each other, and when that fusion peptide enters the host cell membrane, as shown in the bottom panel on the left, that fusion peptide enters the cell, the heptad repeats are attracted to each other, causing hemifusion and then full fusion. So you start with the pre-fusion molecule on the left and end up with this post-fusion molecule on the right. We've applied this same concept to coronaviruses, which have come twice over the last 15 years, once in 2002 and again in 2012 as SARS and MERS, and so we expect beta coronaviruses to be another problem that will emerge again later. So one of the questions is, can we develop a general solution to beta coronavirus vaccine development? We were lucky because we found another beta coronavirus, one that doesn't cause pandemic disease, but it's endemic in our general population, and its spike protein was well behaved. We were able to solve the structure of that spike protein and its pre-fusion configuration, and identify some mutations, just 2 prolines at the top of the central helix that can then stabilize the molecule and not only increase its level of expression, but improve its stability and staying in the pre-fusion form. So what you see here is where those 2 prolines are correspond to places in MERS and SARS spike proteins that also work to stabilize those. So now we can solve the structure of the MERS and the SARS spike. Their protein expression's improved, and I'm showing you in the lower right-hand corner an example of what the pre-fusion spike and the post-fusion spike look like. So now we have the MERS spike trimer solved as a pre-fusion molecule, and it also has better immunogenicity across multiple strains of MERS coronavirus than the wild-type spike, which is also present in its post-fusion form. So let's turn to flu. So just solving the stability problem of some of these class 1 fusion proteins may help make them better vaccines, but in influenza, the hemagglutinin is already well behaved. It doesn't really trigger, it doesn't rearrange itself until it gets into a low pH setting, and so this was the first glycoprotein structure solved for a viral glycoprotein, and Ian Wilson, pictured here, who I think may be in the audience, published this in 1981 with Don Wiley and John Scahill. And Ian built this stick and ball model with his own hands, and really was the first demonstration of how useful it is to visualize and be able to hold in your hands what the molecule actually looks like, and so you can really get to know it at an intimate level. So Ian is, this is the reason Ian knows more about flu than the rest of us. So over time, even though the pre-fusion, post-fusion structures may not be so important for flu, we've known this structure for a long time, but it turns out that the subtle details, the surface topology, matters for making a universal flu vaccine. And so one of the findings has been, along with all the collection of human monoclonal antibodies, is that antibodies to the stem of this hemagglutinin can be broadly cross-reactive. I'm showing you here a hemagglutinin molecule on the left, and the purple, the dark purple, is showing where it's antigenically variable. And you see that the stem is more highly conserved. Monoclonal antibodies have been found that can neutralize either all of group 1 hemagglutinins, all of group 2, and even some can slip in between those two glycans that are circled in red and neutralize both groups of hemagglutinin. So we know that if we can demonstrate that epitope in a way that can induce an immune response, we may be able to have a broadly protective influenza vaccine. So we've demonstrated that. We can put a headless stem trimer on a nanoparticle and show that we can get cross protection between an H1 virus and an H5 virus. And we've now been able to make group 2 stem trimers that can induce antibodies that we know are in lineages that can go on to be broadly neutralizing antibodies. So the question is, how do you design such a thing, and what information do you need? And so I'm showing you a flu virus here on the left, and the reds are the neuraminidase molecules, the blues are the hemagglutinin molecules, here shown in blue. And what we want to do is take the head off, show the stem, make that epitope highly antigenic, and see if we can turn that into a vaccine. So we're going to show you some of the ways we've done this. Transitioning from Ian's stick model, the graphics department has helped us visualize these things in different ways. So these are H1 hemagglutinin and H3 hemagglutinin. I hope you can see the difference. There's a little twist on the group 2. And having this in your hand really is extremely useful. I can't really describe the things you can see that you just couldn't realize before. For instance, this epitope, we just couldn't really see it on a two-dimensional screen, how it related to the sialic acid binding site. But Phil is going to show you, and Megan's going to describe for you some of the new ways we can use to visualize these molecules that are going to be very helpful.
That's great. Thanks, Barney. So Phil and I are with the Office of Cyber Infrastructure and Computational Biology at NIAID, and our mission there is to implement scientific IT tools and technologies to support researchers at NIAID and at NIH, and we also build bioinformatics platforms for the global public. We've been using 3D printing for over 10 years, and more recently, as virtual reality and augmented reality platforms have become more accessible and affordable, we wanted to translate that experience of holding a molecule to actually being able to go inside it. So we're going to do that. I want to say how we got here was thank you. Barney has been an amazing champion of ours for the 3D printing and the VR, and we were lucky enough to have the opportunity with Bill Gates visiting us over the summer in the Gates Foundation. So this is kind of how this came about, and we're excited about it. Now the hardware, before we jump in, you'll see there's 2 infrared detectors here. Phil's wearing a headset that has 2 screens inside. There's 1 screen per each eye, and the resolution is 1080 by 1200 pixels. And then he has 2 wireless controllers in each hand. And those lighthouses detect 70 sensors between the headset and the controllers. So we can turn it over and you'll be able to see what Phil is seeing as we're running the Chimera X software from University of California, San Francisco. So this is currently an alpha version of their software that we've been experimenting with.
So is the
Go ahead.
screen mirrored?
Yeah,
Okay.
we can see you, Phil.
So here's a hemagglutinin, just like Barney was showing the 3D prints for. And I'm in this space. This molecule looks to me to be about 6 feet tall. As I move close to boundaries with either myself or one of these hand controllers, you see a grid appearing showing the space that's been mapped for me to walk around in. However, as you'll see in a few moments, the molecule can extend beyond that space. Now, UCSF Chimera is a full-featured molecular modeling program, so this is not just a simple static view that we're looking at here. We can control the view. So like, for instance, we can change this blue color to show you how each of the 3 subunits of the trimer can have a different color. As you see, I can just reach out and grab the molecule, and it's like I'm holding it at the end of a stick here and manipulating it. I mean, this is a complete 3-dimensional way of interacting with a molecule and visualizing it at the same time. And again, as we look down from the head, you can see that we're working with a trimer here. We can also go inside the molecule to a large extent. And as you can see, I'm just grabbing and holding the molecule. But now let's make one of the chains transparent. And now the surface is transparent, and we can see a cartoon ribbon inside of this surface of the backbone trace of the molecule. And down here, we have one of the amino acid side chains shown as a stick figure. This is the TRP21 residue. And I can point to it and select it. And now we can manipulate it, for instance, change it to a space-filled representation. Now, using both hand controllers, I can make it very big so we can get very close inside view of this particular part of the molecule. Other things we can do is we can turn on and color code to show interesting features such as the glycan binding sites, which are now shown in red here. And so you can see where all the glycans are bound throughout the molecule. And this is just one example of a kind of interaction that you can have live with the structure as you're viewing it.
So Phil, now that we've got to this point, help us design our vaccine. Show me where the sialic acid binding site and the receptor binding pocket is, because that's the primary target that conventional vaccines use. And so that little red spot in the middle is the tyrosine at position 98, and that is the sialic acid binding residue. And we know there's antibodies like CH65 that can have a footprint around that residue, as shown there. And now you can add the antibody. We can see how the antibody can attack that molecule from the top. And Phil, why don't you describe what you see inside there?
Right, so it looks like this antibody is binding pretty well to this binding site, but there's a little opening here. And what I'm going to do is I'm going to go close and make it big. So I am now inside of the binding interface between the antibody up here and the hemagglutinin, which is down here. And you can see it's like a big room or a cave. In fact, one of my collaborators, who is an amateur cave explorer, calls this molecular spelunking. And you get a feel for the 3-dimensional relationships of all of these features in a way that's not really possible any other way. You can see that there's 2 access sites to solvent, how big they are, their relative arrangement, and even more, this is not just like looking at a 2D or a 3D monitor. You can walk around inside of it. You can look behind you. You can look up. You can look down below your feet. So this is a full environment, and you feel like you are actually in this space.
Okay, so the problem with attacking the head is that you saw that a little spike coming down. That's the CDR3 loop of CH65. It's a very unusual antibody that can bind the rim and still reach that pocket with that long loop. And typically, those kind of antibodies don't happen with our conventional vaccines, and that rim blocks access to the loop. So we're going to go down to the stem now and see how to attack the TRP21 pocket. And so can you show me where CR6261 binds? This is a footprint mapped by Ian Wilson. Since he knows so much about flu, he knows how to find these antibodies. And CR6261 can neutralize all group 1 hemagglutinins. And can you show me the TRP21 binding pocket that this footprint centers around?
You can see I'm kind of poking my head around the corner here to get a feel in real space of what this might look like.
And we can add the antibody now. That's where the antibody binds. And now let's go and look at that interaction.
And now we're inside the binding interface between the antibody and this site. And you can see, oh, there's really not a whole lot of space here. And this one compared.
And so one of these interactions is a model, and one of these interactions is an actual structure solved by Dr. Wilson's group at Scripps. Who can guess which one is which? So this is why modeling doesn't really work as well as we'd like it to. You really need to have the data. You need to have the actual structure to see that kind of perfect contour fitting that surface. Okay, now let's come back out and let's go down the trimer and figure out how to make our headless stem. And what we want to do is be able to cut the head of the hemagglutinin off without unraveling the stem. And so if we can go right up the middle between the trimers and stop about right there where some of those loops are, maybe a little higher. Yeah, go right up through there and a little higher. And those, there's some loops there that basically can be tied. So we can create new linkers and tie these loops together and hold the top of the hemagglutinin together of the stem. And then at the same time, in between those helices, we can change the chemistry of those helices and also use that to hold them together in a better way. And now have been able to create stem antigens that mimic the antigenicity of the native trimer. So, thank you very much, Phil.
And see again, I'm inside the protein now, and it looks like it goes back about three stories.
Just don't fall off the stage.
So Barney, do you want to show your last bit of your slide there?
Okay, yeah, well, maybe advance to the slides.
There we go. Oh.
So one of the other aspects of this is that these molecules are dynamic, and not only do we need to see the actual structures and the geometry, but we need to be able to see the motion. And I'm not sure why this is not moving, but it should be moving. Can you play the movie for us? Anyway, those receptor binding domains on the top of the spike turn out they have to flip up in order to be recognized by the receptor. So these molecules, these are 15 million times bigger than the actual molecule on the surface of the virus. And so these are tiny machines that move and reach and grab things, and then that peels off for the rearrangement to take place at the base of the molecule. So the next step is getting movement into these structures.
Yeah, so I think that would be nice to see in VR. And what we want to finally leave you with is that this is a great application. It's fully interactive. It provides something that you wouldn't be able to see otherwise. And it can be used for other different kinds of 3D data, like microscopy data, medical imaging data. And VR is being used for training simulations. and it's relatively affordable and accessible, and we really think that there's something much more beyond the wow factor that you get when you experience this, but something real to be gained from it. And special thanks to the Chimera team that have developed this, and all our supporters, and especially Barney and Michelle Crank, who've done a lot of great work with us and been great champions of ours. Thank you.
All right.
Thank you so much. Very cool. Thank you very much. Thank you to the team. Vaccine discovery is so fundamental to global health, and it's exciting to see the cutting edge of the field. Thank you, the National Institute of Health. Your work is an incredible gift to the world. Thank you very much. Now we're going to host, thank you. So now we're going to host two back-to-back panels, specifically about pandemic preparedness, to help us think about where we've been, where we are, and where we're going. Let me just say a little bit about logistics. We're going to run the panels back-to-back. We're going to invite some people from both panels back up for a Q&A session, so prepare your questions. To help us transition to that session, I'm going to invite Trevor Mundel, the President of Global Health at the Bill and Melinda Gates Foundation. Trevor has been at the foundation for 6 years now, and under his leadership, we've been laser-focused on translational sciences and what it takes to turn great ideas into solutions that save lives. Nothing makes the need for this sense of urgency clearer than the threat of pandemics. Please welcome Trevor Mundel, our President of Global Health. Thank you.
Thanks for this. Thanks, Kadist, and good morning. I did want to start off by paying tribute to the great organizations that make this meeting possible, both in finance but also in substance. There's Grand Challenges Canada, our stalwart partners right from the early days. The Wellcome Trust, so ably led by Jeremy Farrar. And you had a sense yesterday of that tremendous clarity of vision that Jeremy has for global health, and also the ambition that he has. But mostly in Washington this year, I want to pay tribute to those parts of the US government that have formed such a stable basis for our global health endeavors and for this meeting indeed. USAID, which has brought not just dollars to the meeting and to global health, but a real focus on innovation, both in delivery and in thinking about the components of what is happening. And then our partners at the National Institutes of Health, of which you saw a tremendous example. With their leadership, Francis Collins, Tony Fauci, also Roger Glass at the Fogarty Center, they have been so central to these endeavors in global health. And once again, not just bringing investment, but a real commitment, investment of their time, their thinking, their guidance across so many areas. I have a little bit of a confession to make, that you may all have different views of this meeting and have the reasons why you're here. I look on it a little bit as a fantastic recruiting opportunity to find great new people to enter into the global health enterprise. So whenever I've been recruiting folks and they've been on the fence, should we do this? It's a different way of life. We would change our whole direction. I've invited them to come out to this meeting. And in fact, indeed, that's how I was able to recruit Chris Karp, Linda Stewart, two great members of our community a couple of years ago. And why is that would be the case? And I think it's really two reasons. Firstly, people are interested who are coming from a science background. Is there real science? Is there really solid science going on in this area. And I think you'll agree with me following yesterday, and I think what will happen over the next 2 days. There's an incredible amount of cutting-edge science that is being deployed now in solution of the major global health problems. That's well and good. You can get great science in a number of different disciplines, of course. But what I think really changes people's mindsets is the community over here, and it's your spirit and your energy and that extra bit of passion that you bring to this work. And that's what they've all remarked to me. They came to the meeting and they were interested in the science, but they said this very diverse community that comes from 52 countries, that comes together once a year, but in our diversity many, many times, have many interactions. That's what really attracts them. So this year I'm looking forward to a bumper crop of new people joining us in global health. We have 2 important discussions for you this morning. And at face value, talking about cross-sector collaboration for pandemic response, and then a coalition for advancing research and innovations in Africa, might seem to be 2 disparate topics. But there's some very strong linkages, and I hope they'll come out even more during the panel discussions, and there'll be a Q&A afterwards, so you can bring them out if you think that they haven't been made. The one thing that we saw during the Ebola epidemic was the outsized impact of that epidemic in relation to the actual virus and its effects on West Africa, due largely to the lack of healthcare infrastructure and the capabilities in areas such as surveillance, microbiology, that led to that being so devastating. So that as much as there's part of the response which is focused on how do we have better tools, how do we technologically have a better response, there's another and at least as important, maybe more important part of the response, which has been around how do we develop the human capital in Africa that would prevent such a tragedy from occurring again. So for the first panel, I'm going to invite the panelists to come up to the stage over here. And they are in the green room now. And there they are. So if you folks want to just find a seat over here. And I'm going to introduce the panelists. We'll start from my left over here. Camilla Stoltenberg, Director of the Norwegian National Institute of Public Health. John Nkengasong is Director of the African Center for Disease Control. Penny Heaton, CEO of the Bill and Melinda Gates Medical Research Institute. And Richard Hatchett, CEO of the Coalition for Pandemic Innovations.
Epidemic Preparedness.
Preparedness Innovations, CEPI, we'll refer to it in short. So these folks have all been involved in the pandemic response, but I'm going to just quickly have a snapshot from each of you. It's been 3 years since the official end of the Ebola epidemic, although there have been reverberations since then. What, from your perspective, has been the progress or key insight that you've had since that time? Camilla, maybe we start with you.
We can start with me. Good morning. Well, I think the key insight is that there are still many weak health systems, including weak disease surveillance systems. So in the affected countries, that led to an unpredicted and rapid spread both nationally and internationally before the alarm sounded. And there is a need for external evaluations of national capacities for public health. Until now, reporting of the international health regulation capacities have been only by national governments, and peer-to-peer evaluations will give a better understanding of the needs and gaps. And we think that that's one mechanism that should be used more extensively than today. That's demonstrated by the use of the Joint External Evaluation Tool under the IHR. And when the gaps have been identified, there is a need for stronger efforts to ensure that gaps are linked to costed action plans with sustainable funding that can address them. That means that this is not a quick fix. This might indicate support to some 50 or more countries for at least 10 to 20 years. This is a long-term endeavor. In building human competence and capacity, surveillance systems, better labs, and general health services at all levels. And across these issues, there is a need for integrating and strengthening research and development and innovation.
Great, thank you. And I know a lot of progress has been made against some of those goals, but obviously that's a huge agenda, so we'll wait to hear what happens. John, from your perspective, progress.
I think, thank you, first of all, the organizers for giving me the opportunity to represent the Africa Centers for Disease Control and Prevention in this very important panel. I would argue that there's a lot of progress has been made since the Ebola outbreak that we all witnessed in West Africa. What Camilla said is true. I mean, you have to develop, there's still a lot to be done in terms of developing capacity, and we know capacity development takes time. Let me just mention 3 things that have happened fairly quickly over the last couple of years, actually 2 years. One, there's greater awareness in Africa that we need to consider these disease outbreaks seriously. We need to take them seriously. The recent outbreak of Ebola in Democratic Republic of Congo was a good example of where we shifted a slow response, which characterized the epidemic in West Africa, to a fairly rapid response and a fairly rapid response in DR Congo. I mean, that was because of the awareness that was created there. So the country leadership was strong. WHO, Africa CDC, Médecins Sans Frontières, we all rushed in there within days, and we know what the outcome was, 4 deaths, and within 2 months we declared the epidemic over. And then we further deployed staff at the borders between DR Congo, South Sudan, and Central African Republic, because those were really countries that are struggling in terms of security. We didn't want anything to cross into settings that, so that response characterized a whole shift in the way and manner in which we consider threats there. Secondly, the rapid response teams are all over, Africa. We currently have about 1,000 people across the continent that are ready to react quickly to those, and those that I referred to, that we're monitoring the borders between South Sudan and Central African Republic. We're part of these rapid response forces that we have trained over the years and their deployment. And lastly, coordination and pandemic governance. At least, as I mentioned, the leadership of no one will replace a government of a nation to protect its people from outbreaks. Absolutely no way. Partnership is important, but the government leadership is absolutely important there. And the government of DR Congo demonstrated extraordinary leadership in coordinating the partners' activities there. So I think those are some 3 areas that we have seen remarkable progress there. But yet, of course, in terms of capacity development, there's a lot to be done.
Excellent. Thank you, John. Penny, from your perspective, progress?
Progress. So I think we need to be able to respond faster. That's detecting outbreaks early or having the systems in place to respond. And so what the other panelists I said, I think, is of utmost importance in the beginning. But where I think we've really made great progress, when I think about it from my perspective, is on the technology front and in the regulatory front. So on the technology front, I think there have been a lot of advances in platform technologies that could actually address any number of pathogens so that we can respond more quickly. We've seen great progress with vector-based systems such as VSV, with MBA and other vectors. And we've also seen really good progress in the nucleic acid, with the nucleic acid platforms, be they coding for antigen or antibody. You know, let's take DNA, for example. You know, it's been a struggle to actually be able to figure out how to deliver it so it has the magnitude and duration of antibody response that we would need. And there's been great advances made with new electroporation devices that are much more streamlined, easier to use. And I've been really encouraged by the progress in that area. With RNA, there's been issues with formulation and protecting it from, you know, proteases, et cetera, so it can actually get to the cell and induce the immune response or the antibody that we want. And so I think, again, a lot of progress made in that RNA formulation front. So those are two areas that I think are particularly exciting, and of course, I think also have a lot of application for global health and for the diseases, you know, that we're targeting in the poorest countries. So that's one area I'm encouraged. We still need to make more progress. Is it perfect? No. Do we have all of the answers? No. But are we making incredible progress? Yes. I think the second area where we're making good progress is on the regulatory front. And, you know, I know CEPI is working with WHO to really understand where were the gaps in the process when the Ebola crisis occurred, and how can we address those gaps? So really looking at harmonization of reviews of protocols, you know, really aligning on what needs to be done when there's not an outbreak going on so that we can make sure we're ready when the outbreak does happen. You know, how can we be prepared with, for example, preparing pandemic stockpiles to be ready for an outbreak? And then how can we get alignment on the study designs and the process and approach for when an outbreak occurs for actually taking a vaccine through to licensure, for getting the efficacy data, the safety data, et cetera, during the context of the outbreak and getting licensure. So, you know, is there still a lot of work to be done in those areas? Yes, but are we having the right discussions? Are we, you know, do we have the right people sitting around the table? Yes, so I am encouraged.
Excellent. Richard, you're on the spot for quite a bit of this. So what's your snapshot of the progress that's been made?
Great, thanks, Trevor. I think I would, just to build on what Penny has described in terms of the technology progress and the regulatory progress, I would say that there's been a remarkable convergence, particularly since Ebola, both in terms of institutional platforms that have advanced or been created, CEPI being an example of an institutional platform that's been created, Africa CDC perhaps being another. Some initiatives that existed prior to the Ebola epidemic, the Global Health Security Agenda has advanced. They've advanced the joint external evaluations that Camilla mentioned. That's one piece that's terrific. The second major advance, I think, has been a political convergence, that this is actually one of the most important and pressing problems of our time. And the fact that we're having a plenary session on this topic, I think, is illustrative of that. The fact that 6 sovereign countries, the Gates Foundation, Wellcome, came together to create an institutional platform in CEPI is another example. That convergence of the advance of the institutional platforms, the political commitment that really does seem to be shared globally now, which is really exciting, and the advances that Penny described in terms of advancing technology that has the promise to create platforms, rapid response platforms, as well as an understanding of the regulatory challenges and the advancement of regional efforts such as those represented by AVREF to address these problems prospectively. All the trend lines are pointing in the right direction. Penny said there's lots of work still to do. I would completely agree with that. CEPI's only existed for about 8 months, so I'm not going to claim that we've solved the problem, but I think things are going in the right direction.
No, thank you, Richard. I mean, I do agree with that. I think CEPI was probably the institution most rapidly constituted by global health that I've come across. That was quite remarkable. Okay, I'll concede there's progress. But do we really have the means right now, or do we have line of sight to be able to deal with what people call the big one, another 1918-like epidemic, a fast-moving respiratory pathogen? Are we there? Are we going to be there in the near term? Camilla.
Well, I'm not certain we're there, but I think there is preparedness and there is work going on to prepare better for that. And just to mention one thing that we have been involved in ourselves from our institute is a laptop exercise, actually, that we've been doing in the countries where we are working directly on building and strengthening public health, national public health institutions, which was on a respiratory agent much like the one that you're describing here. So that's been done in Ghana, Malawi, Moldova, and Palestine, where we work. That's just a small example, but I don't trust that we're there for the major respiratory epidemics or pandemics that may spread rapidly. And therefore, I think that we need to continue to work now on strengthening health systems in general and epidemic preparedness specifically, and that the two must come together, because there will be no preparedness if the health system itself doesn't function.
Thank you. John, you'll have the resources. You'll be ready in a couple of years to take care of the big one.
Let me agree with what Camilla said with respect to bringing the responses closer to the countries via a concept that we are promoting aggressively at the Africa CDC and the African Union, which is for each member state to establish their National Public Health Institute, which is their mini CDC. So we want to see all 55 countries have their own mini CDCs. And secondly, we want to see these mini CDCs network regionally, okay, around what we are calling the regional collaborating centers for Africa CDC, and there are 5 of them in Cairo, Nairobi, Lusaka, Zambia, Libreville, and Nigeria. So the concept is that in order to prepare and be effective to respond to what you just described, Trevor, we should be able to rapidly detect and act on. Because the question is not whether these dangerous pathogens will occur or will emerge. The question and our responsibility is to detect them early and blunt them, so that we don't even get to the situation in 1919. I think that is our strategy. And by having these regional hubs, which we're calling them disease intelligence hubs across Africa, and working closely with WHO in the region, I think we hopefully will be able to have enough intelligence to say, there's something strange happening, and we will be able to respond. We just, in the next weeks, we'll be launching what we call a Project ECHO, which is a visual system where member states in each of the economic region, excuse me, will be able to network visually via video conferences on weekly basis to discuss any rare events in the region.
Great, thank you. Penny, those new platforms that you talked about, I'm feeling comfortable. They're going to take care of that big one.
We're getting there, but I don't think we're there yet. But I do think we have made amazing progress. And just to go back to what John just said, I do think for a fast-moving epidemic, to be able to detect it early and try to shut it down before it becomes widespread is the most important thing that we can do. But continuing to work on these platforms, and I think the approach that WHO and CEPI has taken, I think we need to continue to strengthen that to get there. So what can we do? Taking the list of pathogens that we know are at high risk of causing another outbreak, and making sure that we're ready to respond to those with these, utilizing both these new platforms and some more traditional approaches. I think that work is progressing well, and are we there yet? No. Will we be there in 5 years? We'll be a lot closer. Will we be there in 10 years? I think we should, if we can get the community to continue to support these efforts as they're supporting them now, I think we could be there in 10 years. With respect to platforms for the unknown pathogens, so this is where, as I was referring to earlier, the nucleic acid platforms become very important. Some of the vector-based platforms become very important. I think what we really need to be doing is, as they are doing, is to demonstrate proof of concept with pathogens that we know. Yellow fever's a good one, flu's a good one, pathogens that we know, demonstrate that proof of concept, show that they work, and then actually have some exercises and see, how fast can we, if you're given an unknown pathogen, how fast can you actually get to product? Let's upload some sequences on the screen and on the computer and send them out to the institutions with these capabilities, with these platforms, and let's have them do the exercise to see how fast they can go, where are the gaps, and how can we begin to fill in those gaps. But you know, if we're going to be successful in doing all of this, we have to keep our eye on the ball. You know, I worry, I remember, you know, when I was back in the private sector and SARS happened, and then, you know, H1N1 and MERS, et cetera, like right after the outbreak and the crisis, there would be a lot of interest, and then it would die down. And you know, I remember I was at a small biotech, and you were working on SARS and, you know, thinking about Ebola, et cetera, and that was like 2006 to 2008. But you know, when the economic crisis of 2008 hit and everything kind of slowed down, and those things sat in the refrigerator, in the freezer, and you know, what would have happened if we would have had the same intensity and maintain that intensity, you know, all the way through from the time of the SARS outbreak to the time of the Ebola outbreak? Would we have been much more ready? And so that's what I would say. We have to really keep our eye on the ball, keep the intensity, keep the urgency, don't become complacent. These outbreaks are going to happen again, that's for sure, and we have to be ready for them.
So Richard, you know, we've invested in CEPI, and you're putting together a very strong organization over there. And I'm going to turn the folks that work with us back to the epidemics that are ongoing every day in global health, malaria, HIV, TB, and you've taken care of this, and the big one is going to be confronted, right?
So to answer your question about are the lines of sight there, I think the lines of sight to the goal are there, but is the pathway clear? No, I think we've got a lot of brambles and tangle that we still need to clear to get there. I would say, look at, you talk about epidemics that are occurring every day. The number one pandemic threat is obviously, I think everybody on stage and probably in the room would agree that it's flu. We went through a pandemic in 2009, and in 2009 it took us about 26 weeks to deliver vaccine from the identification of the new virus to the first doses being ready for use in the civilian population. That was way too long. The vaccine didn't become available until the fall wave had peaked, and if it had been a bad virus, if it had been the big one, it would have been too late. Have we improved since 2009? Could we do better than 26 weeks? I think marginally. But you know, in the U.S., we have, since 2009, we've licensed a cell-based vaccine. We've licensed a recombinant vaccine that potentially shorten those timelines just a little bit. But have we developed a universal flu vaccine? No. There are lots of technical challenges still ahead of us on the science side. Have we developed better therapeutics? There's lots of exciting work being done with monoclonal antibodies approaches and gene-encoded antibodies, but have we developed them? Are they available? No, they're not. In terms of getting to that goal of being prepared for the big one, that's just the technical side and the substantial technical problems that still need to be solved. There's also the institutional and the organizational and the coordination side. We talked about surveillance, the importance of improving surveillance. That's spotty right now. Picking these diseases up early gives us lead time in terms of developing countermeasures. It gives us the opportunity potentially to contain or quench these epidemics before they spread globally, and we clearly don't have the systems in place. I think John has a hard job ahead of him. We know
what is the realistic ambition?
What's that?
You said 26 weeks is not adequate, and we've tweaked that. What is the realistic ambition?
For flu?
For the next couple of years.
I mean, I think. Well, let me also contrast the 26 weeks. When we started to respond to the Zika epidemic, we had an aggressive but from scratch vaccine development effort, and we were aspiring to having a vaccine that was ready for emergency use, not even a licensed vaccine. This was when I was at BARDA before coming to CEPI, in 26 months. And so 26 weeks is the very best case for a virus that we know, where we have a platform that is already pretty well established, where the regulators are comfortable for virus X, for the next pathogen, we've got to do better than 26 months. If it moves as fast as flu, if it's a respiratory virus, the goal has to be 12 weeks, maybe 15 weeks. It can't be longer than that if we want to be able to vaccinate and immunize people, and it takes time to produce immunity.
Okay, great, thank you. Well, I want to take you folks forward. 10 years hence, and a report comes out from Gulu province in northern Uganda of a highly infectious virus outbreak, which turns out to be a filovirus. And sadly, 47 people die, but the outbreak is contained. What did your organization contribute to that state of the world?
I think the first thing I'll mention is what I already told you, that we will contribute to training and collaboration on strengthening and building institutions with public health capacities across the world. So Norway, or the Norwegian Institute of Public Health, is now working with 4 countries, but we hope that there will be others that will work in similar ways with other countries. Now, that's one contribution, it's a small one, but then, as I said, we had a laptop exercise that was very similar to that exact event. But the other important thing is to continue to support CEPI. We were instrumental in establishing CEPI, and we're now hosting CEPI, and we're very proud of that. CEPI is now independent of the Norwegian Institute of Public Health. But what we can contribute is both scientific capacity, but even more important, on the policy side, to continue to create and maintain support and funding for CEPI and similar mechanisms or related mechanisms that are needed and that we must put in place to be able to meet such a threat.
Thank you.
10 years from now.
I must recognize Norway's unique contribution to CEPI and this response. It's been fantastic. Thank you. John, what is the CDC for Africa actually doing, and what did they do to stop this?
So what did they do to stop this? I think, in my perspective, it would have contributed in 3 areas. One, the workforce development, that you need a I would say a multitask approach to that. I mean, do we train epidemiologists and deploy them there to support the National Public Health Institute in Uganda to be able to respond to that in the areas of field epidemiology, laboratories, risk communication? That is extremely important. We would say, point to at least those areas and say, thanks to these areas, we help them. Secondly, secure funding. I mean, do we support the government of Uganda with some funding to be able to respond to that? Because the number one request that we get each time a member state is challenged with these outbreaks is that funding, support us with some funding then. Then lastly is really showing the leadership that you can, as Camilla said, that each of these countries must have their emergency operations centers that are linked up with the Africa CDC Emergency Operations Center, the so-called EOCs, which was very effective when this Ebola outbreak I described in DR Congo occurred. We immediately activated the Emergency Operations Center, linked them up to the neighboring countries, and to be able to coordinate the responses there. We will do the same in Uganda.
Great, thank you.
I have a quick remark. The first thing I would have done would be to contact Africa CDC and John and ask them, what do you need?
That'd be good. So Penny, you've now developed a vaccine for TB, which looks exciting and promising, and you have this great second-generation vaccine for malaria. So you actually reprieved from having to answer this, except that you work on a number of the WHO task forces. So what did WHO do about this?
Yeah. So I think, and a few areas where WHO is super critical. One of the things that I think they would do is by supporting the emergency operations centers in the countries so that they could actually respond quickly and shut this outbreak down before it becomes widespread. So if we only had 67 cases and it was a fast-moving pathogen, I think that would have indicated true success in that area. I think other areas where WHO's role is really would be important is just getting the world ready to go. So having all of the regulatory pathways clear, starting to assemble the partners, et cetera. So if that initial response hadn't worked, that we would be ready to actually move forward if medical countermeasures needed to be developed and delivered to the countries. But I would say that the Gates Medical Research Institute, given my vision for it, we won't be off the hook, I would say. And the reason why I think we wouldn't be off the hook, number one is we do envision, as I said earlier, using the technology platforms for actually, developing, or that could be utilized for developing medical countermeasures against many different pathogens. And so by supporting those platforms for TB, malaria, and other neglected diseases, obviously we would have supported the entire ecosystem with these platforms so that they could be utilized for an outbreak, and those would be ready. But I would also say it goes beyond that, because really what we hope to do, as we've talked about many times, by being located, in Cambridge, in the US, we are accessing the latest technologies. But the idea is not to leave the technologies there, but to actually have, our collaborators from low-income countries in Africa, in India, and Southeast Asia to come in, to learn, and to be able to take that back out to their countries. So perhaps we will have contributed in a different way by actually having, some of the first responders, some of those who are setting up the systems within the countries may have gotten some of their training, some of their knowledge, and their support from the Institute. So I think that we really aren't off the hook.
Okay, well, we'll have to discuss that.
So that's the vision.
Very good. Richard, Seppi, did it have any role over here? And I see that Kadest is coming to warn us that you have 30 seconds.
Yeah, so let me say that you were optimistic in asking the question, because CEPI only has 5 years of funding, so I'm going to be optimistic in answering that we're still around to play a role. I would say in 10 years, we have a filovirus platform that we've already demonstrated works for Ebola, for Sudan, for Bundibugyo, for Marburg, and the regulators, as they have with flu, have gotten used to the platform. And so John, with his beyond next-gen sequencing capability in his BSL-4 lab that he's developed in Addis, as soon as he gets the virus from the outbreak in Gulu, he sends me a sequence. And because I have either a gene-encoded platform or I can use synthetic biology to develop a cassette, I can put that right into the Philo platform that we've got. The regulators already know it, and we've been working with the regulators in Uganda for just such a contingency. So I don't know if we have anything to do with quenching an outbreak after 67 cases, but we certainly will have our vaccine within 12 weeks.
Excellent. On that note, I do want to thank the panelists for joining us this morning. And I think we're going to move on to our second panel. So all of you, thank you very much.
Thank you.
We're spending a lot of time with the community.
Until we rid our beloved country of this dreadful unwanted guest, Ebola.
Community leaders with our colleagues to assess how to better handle this Ebola epidemic.
My big question, and I guess it is the concern of everybody here, is this a wake-up call for you, also the international community, to start looking at other potential viruses that may come to harm us, as vulnerable as we are in the future, so that we start putting things in place now for us to prevent us getting those type of situations.
Well, to be honest, in this 38 years, we have collectively failed. And every time when there's a big epidemic, we say, oh, never again, and we are going to, put in place mechanisms to do this and that, and it doesn't happen. And so we have to now really fight that this will happen this time, and that there are better systems in place.
I communicated with the ministry that GFK should close down. So we just transferred the team from JFK to MOD.
Ali, check this. The scrub slippers and clean and the booster. The extra boost in my office, I don't know who got it.
I created something called coordination team.
Oh, good morning. Yesterday, I started getting complaints. There were 2 patients that were brought to the triage, and they were lying down in the triage here for more than an hour, waiting to be taken to the ward, and the nurses were informed. I mean, every patient that come here, think about your relative being in that position. You don't treat patients like that. You can't have patients waiting in the triage for 1 hour, before they get care. We need to be vigilant about it.
I've seen so many people die, then sometimes I'm afraid of being a medical doctor. One laboratory technician working for us at JFK got infected. Then my hygienist, who got into a physical fight before the patient, became infected. Then 2 securities got infected at home. Then Dr. Scarlett got infected. After I joined JFK, 3 intern doctors came, including Scarlett. Dr. Scarlett always wanted to walk side by side in a unit with me. And when everyone else is tired and walking out and I'm in for 4 or 5 hours, Dr. Scarlett, they will stay. I mean, this was the perfect friend, the perfect colleague. One day, he took the day off, and then that evening, I called him to see how he was doing. He said, Doc, you know what? This evening, I just had sudden chills. I said, shh. I said, okay, keep it calm, come to the unit and we'll take a sample. That night, the first thing Scarlett did was to call me. He said, Dr. Moses, guess what? My result came back acute positive. I started to cry, started to shed tears. Then I told him, I'll do everything in my power to make sure you're okay. I will get an ambulance. And then the ambulance came, they received him, they took him in. They did everything they could do for him. They managed to preserve him that night. I kept calling all through the night. I didn't get him, he didn't talk to me. The following morning, he just dropped and died. He just dropped and died. He just dropped and died. Yeah. Many patients have survived our unit. But up to now, when I think about it, I feel like I've done nothing. I didn't save Scarlett.
So folks, we're back with panel 2, very much connected with the tragic events portrayed in the video here. I want to introduce our great set of panelists over here. Firstly, to my right, President Amina Gurub-Fakim of Mauritius. Thank you for joining us. Tom Karaoke, Director of AISA. This is the Alliance for Accelerating Excellence in Science in Africa. Dr. Francis Collins, Director of the National Institutes of Health, and Jeremy Farah, Director of the Wellcome Trust. The first question I have for you around Kerry, this is the Coalition for African Research Innovation. When I've spoken to folks, I get a number of different descriptions of what CARI is and what it might do. So I wanted to just go through the panelists and get your view on what is CARI, what is its potential, just a snapshot. Madam President, I want you to backstop that. So you'll have the final word. And maybe we can start with Tom.
Thank you, Trevor, and it's a great opportunity to be here. I think CARI has the Africa in it, so let's start with that question of why Africa now. I think based on the panel that I've just completed the session, I think it's clear that we really need a focus on Africa because of all the various issues, both the opportunities and the challenges. It's the continent that is going to be probably the source of another, epidemic. The hotspots are there. It is a continent that also has so much promise for the future in terms of future source of labor markets and future source of labor for all the world, considering the population growth that's happening there. And therefore, a focus on Africa is important. The research and innovation agenda is what will inform our preparedness to deal with epidemics, our preparedness to deal with socioeconomic issues. And so we have been able to, at the African Academy of Sciences, we've been thinking about these issues for the last 32 years of the existence of the Academy. And recently we created this AISA platform that I lead there. And that is based on a number of things. Jeremy yesterday talked about shifting the center of gravity to Africa so that we can set the agenda for Africa, we can prioritize what we want to do, and we can begin the program implementation to support some of the things we want to do, building platforms in Africa that address all of these issues. And what we have done, therefore, is to also create a business plan around what are the focus areas that we want to sustain in Africa. We need investments in research and development. We need investments that focus on delivering innovations through the delivery pipeline from discovery to development all the way to commercialization. We need a focus on young people, establishing postdoctoral programs in Africa, making sure young people have a future in science, they can live, they can work, they can thrive scientifically in Africa. And we need to also plug the gaps and the weaknesses in our research ecosystem. Everything from how we look at financial governance, to how we look at community engagement, to how we look at career pathways, all of this is part of the ecosystem we need to build. So building those models with major programs like Deltas, for example, we have been able to look at clusters of networks that address some of the issues. Just another example, you have a One Health cluster that would cut across 10 countries, and therefore what you're doing is you're bringing together scientists and capacities that can address the One Health approach across the entire continent. Now, those becomes clusters of excellence that we can actually then begin to address issues around how we train epidemiologists, we train immunologists, we train microbiologists, we train entomologists. All of that can be done with those clusters of excellence because you're focusing on scientific excellence, you're focusing on training and mentorship, et cetera, et cetera. But then the key question, and this is where CARI comes in, is how do you sustain all of that? Are we thinking short-term here? And I think the previous panel mentioned this. We need to think long-term. We need to make long-term investments. So CARI is a mechanism for us to think long-term. It is a mechanism for us to think systematic collaborations, because collaborations and partnerships will be key. It is a mechanism for us to mobilize additional resources, but also, critically for me, it's a mechanism for how we bring more actors into the research and innovation space in Africa. At the moment, it is global funders like NIH and Wellcome doing a lot of work there. It is governments trying to do as much as they can. They could do more. But it's, the space is missing some of the key private sector players, civil society, philanthropists. I hear there are many billionaires in Africa. We also need to see them come into that space. That is missing, and that is really, for me, what CARI is about, mobilizing all of these actors together.
Okay, great. So support for this very broad vision you have of development of human capacity in Africa. Francis, your thoughts. What is CARI to you?
Well, first, it's a privilege to be on this panel, and you see in front of you folks who've been very invested in trying to put this idea of a coalition for African research and innovation together. The fact that it's still a work in progress is probably reflected by the fact that we haven't even decided whether this is called CARI or CARI, so you'll hear both of those as the way in which we pronounce this particular acronym. Africa is rising. There are opportunities to build research capacity in Africa that are unprecedented. And yet that isn't going to just happen because we want it to. It's going to take an organized, thoughtful effort to figure out how to move this center of gravity for research support, which has, frankly, been in more of a colonial model for most of the past many decades, and which could now, we believe, be shifted in a way that empowers African governments, African institutions, and African researchers to begin to chart their own course. Not that we're stepping away from support of that. Certainly NIH Wellcome Trust, the Gates Foundation, working with AISA and with the able leadership of the President of Mauritius, see this as an opportunity for us to work as a team, not in any way to step back into the sidelines. But I do think we have a chance here to try to build on some successes that we've already identified that show that this model can work. From NIH's perspective, we have been inspired by the success of two programs I want to mention. One is MEPI, the Medical Education Partnership Initiative, which is funded jointly with PEPFAR, and which has brought together African institutions that had lots of north-south arrangements, but did not have a south-south network that MEPI has created. And those educational institutions that also do research have linked up as a result of that in ways that has greatly increased their capabilities to do research, to do training of physicians and nurses and researchers, and also to have internet connections that were really not so easily present before. That has greatly enlarged their capability for communication and collaboration. The other program, H3 Africa, which I'm happy to say is a joint effort between NIH and the Wellcome Trust, stands for Human Health and Heredity in Africa, again focused particularly on getting scientific progress to happen in the area of gene-environment interactions. And again, funding more than a dozen institutions, each of which has various nodes. We have seen come through that really remarkable progress in science, with publications coming out and with training opportunities for young scientists who really want to stay in their African institutions, as opposed to all too often feeling that they don't have a future there and therefore they must seek a kind of research career elsewhere. Those, while they are projects that have only been in place about 5 years, give me the encouragement, and together with the arrival of AISA as a really important way to hold this kind of network together, that this is the right time to see how we could capitalize on that and to move from what we might have called donorship for African research to ownership, where African countries and institutions really become the owners of their own agenda. That's going to take a lot of work. This is not something that will happen overnight. But finally, I would just say, Trevor, you were asking the last panel about a hypothetical 10-year experience from now where there's an outbreak in northern Uganda. If CARI had by then developed this kind of building of research capacity in Uganda and elsewhere in sub-Saharan Africa, that would be a very different picture, because you would have the research strength in the continent ready to address that in terms of surveillance, in terms of treatment, in terms of public health, in terms of really good research. Maybe that would be where the vaccine would get first made for that outbreak. I know that's bold and ambitious, but that's the kind of people we are, at least in this panel, so I'm going to promote it as long as I can.
That's great, Francis. So donorship to ownership, I like it. Jeremy.
Yeah, thanks very much, Trevor, and thanks for leading this discussion. I actually think this discussion is the most important discussion of these few days, actually, because if together we can move this forward, and as Francis has just said, we can all pledge and all give up some of our own autonomy to come together and shift this center of gravity, which is a phrase that gets said a lot now. And what that really means, and we should not hide it. It does mean making yourself uncomfortable. It does mean giving up control. It does mean shifting the accountability and the responsibility for everything, the finance, the decision-making, the setting of the agenda, who owns it, who drives it, who leads it. And that has got to shift from the centers where we currently have them to the centers that Tom leads and NEPAD support, the African Union supports, African CDC, clearly a crucial partner. And if we can achieve that, then I think we're going to come into a golden age of science in the continent of Africa. And that's what we're here to achieve. So I don't think it's too ambitious. I think it's achievable. I think there's a convergence of ideas around this, And the time is now.
Excellent, thank you. Madam President, you've played such a central role in moving this forward. Can you give us your view on CARI? What is it to you and how you see it moving forward?
Thank you again for this opportunity to speak about, as Jeremy has just said, such an important conversation. It's an important conversation because it is seeing us move from a model of education that, as Francis has said, it has our heritage from the colonial days, and where the focus has not been on science, technology, innovation, and engineering, and the famous STEM that we have to address. And now is a time that we have to take ownership of this, because the needs on the continent are so big. And as Tom has just said, we have the population, the youth in Africa, and I see my role in this as a connector with various institutions, various stakeholders, be it, for example, philanthropy and governments, because increasing governments must see that this is an investment in the human capital in Africa and not an expense. And this conversation has to happen, because we need to see this happening. Now, I see also in this process the emergence of the virtuous triangle of speaking of philanthropy, government, and private sectors. And philanthropy, I mean, of course, donors, and of course, institutions like the Wellcome Trust and Gates and NIH, they're playing a very critical role in this. However, having said this, I still consider this contribution to be seed funding. And the seed funding is the ownership has to be from government to actually keep on ensuring that once a seed has been planted, it needs to be fertilized, it needs to be watered, and this will come from local funds. And it's a work in progress. It's going to be disruptive because we have to really change the thinking process. But I think the focus has to remain that if we are going to make gains in the health landscape, we're going to have to address the translational research, because research is happening in Africa, but we need to see to it that this research is translated into public space for impact. It's going to translate also in terms of IP for generation, of course, of wealth creation. And what we also have to ensure is that this effort is sustained in the long term. We will not make headway if we think only on short-term gains. We have to invest in the long term, and this is where, again, I bring the focus on government role in funding this. Now, how do we get good results? How do we get fantastic results for maternal and child health? If we look at the sectors which are very close to this health paradigm, we look at food and nutrition, we look at hidden hunger. This, for example, if we address it. Now, why it is so important for the African continent is because African continent will be impacted with climate change. And climate change will impact agriculture in big time, because agriculture in Africa is still rain-fed. And while this will not be the mandate of this platform that we are developing, but this is something that government has to be mindful of, that they need to really start thinking along those lines, so that when we are actually going to address the health issue, we have behind all the sectors, all the areas which will impact this sector, so that we get better results down the line. So again, the messaging is that we really need to shift the focus, as I said, the center of gravity to Africa. But one key focus we must not also forget is the talent and the potential that diaspora bring. But for diaspora to come back to Africa, even if it's for what I increasingly coin the brain circulation, we need to create the environment, we need to create the ecosystem that these talented Africans working abroad will be interested to come back to Africa. And again, this is the responsibility for us to create the ecosystem. And again, initially, we'll have a special conversation with donors to see to it that we can, with philanthropy, help build that ecosystem in the same way as other countries have done. I'm thinking of India and China, for example, and other emerging countries where they're investing in that space, because to bring that brain power back to Africa, we need to create the enabling environment for them to come and work on the continent.
Great, thank you. You mentioned talent, and a couple of folks mentioned the development of capabilities. I was having lunch yesterday with one of our colleagues, Fred Sakuma from Tanzania, and talking to him about these issues. And he said to me, well, just give me 10 PhD entomologists in every country. And that would set us on a path to malaria eradication. He mentioned a couple other things as well. So is that what we mean? And I know that the response might be, well, we need all capabilities, but is there a priority, a prioritization? So how do you think, what are the capabilities we're talking about? Is there a priority? Tom, in your mind?
We do need everybody and everything, because I guess the old concepts of physics of critical mass is important for us to move anything forward. I think from the African Academy of Sciences, we are an academy of all sciences, all knowledge. And actually what informs that is that our founders and forefathers thought that to solve Africa's problems, you actually need to think the way Madam President is talking about. How do you bring different disciplines to actually then impact on how you solve a problem? So for example, the nexus of health and nutrition and climate sciences, it's all very important. I mean, as an immunologist, for example, my work doesn't stop by the fact of delivering a vaccine that protects an individual. You also have to think about issues around how do you achieve population-level resistance? How do you achieve herd immunity? And that goes beyond immunology. It goes to the heart of if people are hungry and undernourished, are they actually going to be protected? So the issues, I think, have to do with prioritization is important. Yes, we have to prioritize and say, with regard to some of the key agenda issues, let's not forget the fact that, infectious diseases are critical, the major ones. So we need capacities to address all of those, from entomologists to immunologists to microbiologists. We still grappling with age-old problems of neglected tropical diseases that have been around for thousands of years. So we need to think about, how we don't leave the community that works on NTDs behind as we focus on epidemics and pandemics. And we also now need to bring this transdisciplinary approach into the mix. And again, that requires a new level of teaching and training and mentorship to bring that on board. So numbers are important, and we can throw around the numbers. We can say, okay, if you really want to get to the global average for researchers per million inhabitants in Africa, that number needs to move from 100 currently to 800. But that doesn't tell the whole story. But
great, thank you. Madam President.
I fully agree. The needs are so big on the continent, but we need to deal with this matrix and again look at where the gaps are. And if we look at the global health space on the continent, I mean, again, the numbers, we don't have the numbers already. But I think what also, I'll just react to what Francis has said. What is the state of preparedness for the continent? And how do we look at 10 years from where we are now and look at our ecosystem as it is? The state of preparedness, the training, the capacity building, and this is the bigger picture that we have to see. But having said this, there is also this huge challenge of re-looking at our curriculum, whether we are really training the people correctly and whether we're training for our youth to think critically, whether we bring in the gender focus as well, because we will not win the game if we leave behind 52% of the talent behind. So this is what we want, an all-inclusive approach, looking at the bigger picture, get ourselves a plan. We can tweak it along, but we need to have this plan as to where we're going to go. But more importantly, bear in mind that while there is the issue of pandemics, but there is something else that we also have to take on board, is that with improved nutrition, with improved lifestyle, we will also have to look at non-communicable diseases. So I think we need to look at the global picture, get ourselves the plan, and look at where the gaps are and address these gaps to make things happen.
Great, thank you. Francis, so this is about expanding AISA and MEPI and H3, is that it?
I think you could think of MEPI and H3 Africa and the Deltas program as pilots for what we're talking about on a broader scale, but they're very encouraging pilots that show that this model can work. And I'm not sure everybody believed that until those pilots were put in place, where African principal investigators are the primary leaders of the enterprise, not delegated to some secondary role as a subcontractor, but actually leading the work. And that, from my perspective, has been a remarkable success. And one would want to see, through CARI, the ability to expand that to additional institutions and countries, but then with more buy-in, from African governments to own this as well. Because in my view, it's institutional strength that is perhaps the most important area that needs attention. If you can strengthen research institutions, provide them with the kind of infrastructure they need to be able to do research, to be able to handle complicated financial arrangements, to become partners with private sector in interesting collaborations, then that becomes a magnet for the talent that is the most critical resource of all, the people, to want to stay there and to want to pursue creative ideas. And I do think, just based on the question you asked about, are we looking at basic science, are we looking at much more translational or clinical research, it ought to be up to the African institutions and the African governments to figure out what that mix is, but it's going to include some of those things. And I mean, look at the example of broadly neutralizing antibodies for HIV and what we've learned from that, the fact that it's possible by doing very thoughtful clinical research to come up with an insight that may have profound implications for the ability to develop a vaccine. That kind of thing ought to be possible in a well-supported African institution that takes advantage of both what's happening clinically and figures out how to turn that into something that finds its way into this pipeline from upstream to downstream. And that would be the way I hope that all of this could come together in a fashion that 10 years from now would look very different than it does right now. But again, I can't say enough, and I really appreciate Madam President's being part of this effort and speaking to her colleagues across the continent. It isn't going to happen if we stay with the same model where everything is sort of being decided outside. This has to go to that ownership space.
Great, thank you. Jeremy, your thoughts on that?
I obviously agree with what Francis has just said, and Madam President and Tom. I mean, this may annoy some of my very good friends in the development world, of course, but I really do care about sustainability. But I think you can sometimes worry too much about sustainability at the start. And if you have to prove sustainability on day one, you may never take the risk to just go for it. I'm not sure that Bill himself could have persuaded everybody that he was going to make a sustainable company when he first thought of Microsoft. And we won't get it right. You won't get it right to begin with. But as long as you're willing to learn, and as long as you're willing to iterate, and as long as you're willing to be ambitious, you can change the way you do things. And I think we shouldn't put too many barriers in place, and we should just take a leap and go for it. And the second thing I'd say is that capacity building is not just done. Francis spends most of his life building capacity in the world's greatest scientific country. You'll build capacity 50 years from now, because capacity is about inspiring young people, providing mentorship, giving them the opportunity to take leadership positions. And you're building capacity in the United States of America today. And we will be building capacity in Britain 50 years from now. So capacity building is not something I can give a 5-year time frame to, or even a 10-year time frame to, because we will still be building capacity in all of our own countries 50 years from now. So this is the long term. You're not going to build that overnight and just think you're doing this to put in place those infrastructure and institutions that Francis talked about that can help you deliver that governance, accountability, and responsibility for delivering what you want to achieve.
That's great. That's a very long-term perspective. You know, just coming off the United Nations meetings where there was such a strong focus on the SDGs, Sustainable Development Goals, one could say, at least I certainly believe that achieving the SDGs would be a fantastic effort of this community by 2030 and would almost certainly require tremendous success for KARI and investment in human potential. Otherwise, I don't see a clear pathway to a number of those important goals. But that's in the 13-year future. Just teeing off what Jeremy said, that in some ways one has to be quite vested in the initiation and the early stages of a venture. So as much as we could put forward measures of success of KARI in the more distant future, what about in the next couple of years when this is going to be evolving? What are the key indicators for you that would indicate this effort has actually got traction and is actually headed in the right direction to get us to the 2030 SDG?
I am sure people who deal with M&E frameworks and theories of change can come up with a very complicated way in which we can measure that. But I would prefer to keep it very simple. And again, just building on what Francis and Jeremy have said, it's a focus on people. People are the center of everything that we do. So if you just focus on that and ask, are we achieving some of the things we want to achieve with people, for example? Are we enthusiasting more young Africans to take up sciences? Are those young Africans actually then becoming leaders? Are they remaining on the continent, building actually networks of research excellence in the country? Are we seeing products begin to come out of the institutions that actually have built these capacities? It's about people. It's about programs of work. It's about, are we getting more clinical research done in Africa, and is that research competing globally? Are we getting more translation of innovations through that space, adding up with more patents and products? I think those are good measures for me. It's about places of work. It's about people looking at an inventory of institutions in Africa and saying, here are some great places to do research in Africa because they actually can compete globally and they are in that space. So people, places, programs, simple measures for me.
I like that pragmatism. Thank you, Tom. Madam President, your thoughts?
I think already you mentioned the SDGs. I think it's the first time we have to salute the fact that the SDGs is grounded in solid science. I think it's the first time that even at the level of the UN, there has been recognition that science matter. And I think if you take this messaging now from here, and as you say, in terms of monitoring what is going to happen, I think all the indicators are there. And if you look at already the output of AISA and the Wellcome Trust at the African Academy of Science for the past few years, we're already seeing PhDs, we're already seeing postdocs who are being trained and addressing the needs of the continent. I had the great opportunity of listening to Fedros the other day talking about mosquito science, the entomology, the mosquito man. And so it is already showing that the results are here. But how do we sustain this? What means do we get? And also how to supply the pipe so that we get more and more scientists coming out. I think these are all the indicators that we can put on board in terms of assessment if we have to perform this assessment in a few years' time.
Great, thank you. Francis, how are we going to
I liked Tom's summary of people, places, and programs. And maybe one other component of that as a metric is, have we really succeeded in shifting the source of support from what has been largely an outside source to an embrace by African governments of this, not as a cost, not as an expenditure that's sort of competing against other things they need to do for their country, but as an investment, both in the health of the nation, in the ability to retain talent, and in stimulating the economy, which we believe is actually a pretty compelling case, although still trying to collect the data to support that in Africa. It's certainly true elsewhere. So to see as a serious shift the way in which the foundational support for the infrastructure and for the research and the decision-making process about how to set priorities has really happened, that would be I hope, fairly early metric to see that shift starting to happen. If it doesn't go in that direction, then something hasn't clicked.
Yeah, just picking up on some of those, because I haven't got any more imagination to say anything novel.
You're always at the end, aren't you? It's not fair.
I think seeing really clear political support on the continent and really enthusing about that and having politicians and society seeing this as something to be really proud of, that actually is driving culture, is driving countries forward. I think that political and societal support that I talked about yesterday is going to be absolutely fundamental, and that would be, I think, one huge measure of success. And perhaps the other one would be independent of any of, certainly at this end of the platform, teams working from Tom's team and others with other places, with India, with China, with Brazil, with Mexico, independent of any link back to Europe, North America. That would be also a measure of success for me.
Great, thank you. So what we're going to do now is we're going to retire this panel, and I'm going to thank them for their really thoughtful reflections. Thank you. And then we're going to have a subset of the panelists join us now, and I'm sure that there are folks in the audience just itching to get a word in, a question in. So, yes, Madam President, please stay with us. And then we have Penny Heaton and Camilla Stoltenberg all joining us for the Q&A.
Yep. Do we have mic runners? Do we have questions? I'm going to tee up a couple for you, Trevor, and then let's see how we get there.
We have microphones out there.
Linda, is that you? Yeah, I think that's Linda. Okay.
So just say who you are and then ask your question. And maybe you want to direct it to one of the panelists, or it's just a general question. I'll try and triage it.
So I'm Linda Stewart. I work at the Gates Foundation in vaccine discovery. Earlier this week, I was at a meeting in Rockville on translational science and clinical translational studies and how we can accelerate them. And there was quite a passionate conversation that kind of unfolded around Zika and understanding what we should do to accelerate Zika vaccine discovery. And it brought up a number of, I think, very interesting questions, because there was a huge urgency from some people in the audience about trying to get a Zika vaccine, because we're very sort of conscious of how things were playing out in South America, whereas there was a sort of lack of urgency, let us say, from some of the other people who said, well, the Zika epidemic's gone, and we shouldn't worry, we don't need to worry about it, and so on. And I realized that this sort of disconnect between where we develop vaccines here and where we deploy them in developing countries can become quite profound and create a lot of tension. And so one of the questions I was thinking as I was sitting in this meeting was, do we have, rather than this sort of disconnect, do we have enough translational research occurring directly in the countries where we want to deploy our vaccines, particularly when we know that a lot of vaccines platforms, such as the viral vector platforms, will not translate one-to-one when we go into countries. So if there's background immunity to an adenovirus platform, we may not get the same immunity. So have we built enough capacity for clinical translational studies in endemic settings, particularly so that we can expedite that translation in the context of a pandemic response? So maybe that question is to Penny, I suppose, or Madam President, but it's really around, do we have enough clinical translational scientists in local countries?
Right, we'll take that, I think, in the narrow context, Penny on the clinical translational science, and then maybe we broaden it, because it's, I think it has some general implications.
Yeah, so I don't think we have enough translational science in the world in general for the diseases that we're really working on, the diseases of the poorest. There will be a panel on the Gates Medical Research Institute later today from 5:30 to 6:30 in the Independence salons downstairs. But,
that's just a little plug for that.
Just a little plug to find out more. But the Institute, Linda, as you know, will be focused on TB, malaria, and enteric diseases beyond rota, the Shigellas, Cryptosporidium, et cetera. And, I think that we just haven't made progress in these areas, and why is that the case? And, and so we're going to try an experiment. And as I alluded to earlier in my panel, we'll be, located in the U.S. in Cambridge and Seattle, really so we can be close to the technologies that I think we need from other fields in order to actually successfully develop tools for these diseases. But as I said earlier, I don't think it's just about that. I think it's also about then taking and making sure that technology is, that we have collaborators, partners, students, investigators coming in from low-income countries, understanding our approach to accessing technologies, understanding our approach to actually doing the translational development. There's a real art to that. So understanding that approach and then taking it back to their countries. I don't know what that looks like yet. The Institute isn't even born yet, and it won't be in year one, but definitely in year two, we really want to start to think much more deeply about those collaborations. I just don't think there's enough translational medicine, period.
Madam President, one aspect of this these are new skills, in some cases not present anywhere in the world. And I know you mentioned earlier about the need for new curricula in Africa. Is there an opportunity for Africa to leapfrog into some of the new skills and leave behind the old categories?
I'll just quickly react to that question on translation, and I think just linking up to what Peggy said, is that research is happening on the continent, and maybe not enough in terms to translate into that space for the development. And I see an opportunity here for CARI, because what we can do is precisely do the mapping through what's been happening through the African Academy of Sciences and identify these institutions that are already doing work where it's nearly ready to go out in that space of translation, and I think this will address this. But you're right. Now, how do we reinforce these centers, which can become eventually centers of excellence, but at the same time, as I keep on saying, look at the pipe. And look at the pipe means re-looking at the curriculum so that they speak to the training that we want to see happening. So this is where the long-term approach comes in, but the mapping initially of what's going on and how this can be translated in these low-lying fruits of seeing that, for example, the delivery of the vaccine will happen, or whether the food security program is happening, or something like this. So this is something that we need to do in terms of the mapping of the African continent, where the good work is happening, and then look at the mismatch, and at the same time plug in the necessary funding so that they can emerge faster and be able to be much more responsive to whether the challenges are going to come in the short and medium term.
Great, thank you.
Sorry, so we have two questions, I believe. So one here, I believe that's Roger Glass, and then we've got a second person right in the middle. So first here, second here, and the next one we'll take somewhere from that side, please. Thank you.
Thanks, Kadest. I'm interested in databases that would allow people around Africa to collaborate, to know what's going on, where it's going on, who you could connect to. I know at NIH we've developed with the HEROES group the website worldreport.nih.gov, which lists all the research down to the abstract level for countries which are contributors. But I don't know if through GFinder at the Gates Foundation or other data sources would be available. Certainly the World Report database has just been updated to 2016 and is available for all. Are there other databases that we should be accessing to bring us all together?
Maybe I'll turn to Camilla over here. You have some fantastic databases, right?
We have fantastic databases, but also we work on developing data sets and databases in some partnering countries, particularly in relation to maternal and child health. It doesn't really respond to your question, because I think access to databases with literature, with reviews, etc., is essential. But that is a fairly easy challenge to meet. What is more difficult is to develop health information systems that can serve many different functions. So they can serve regular services, diagnostics, follow-up of patients access to their own information, but also research and emergency preparedness. And what we should try to avoid is what we've done in many other countries, in European countries, etc., to create very fragmented systems where we have one set of data for emergency situations, another set of data for running our healthcare services, and another set for regular research. So we should try to work on that in a very integrated way, and I think it's an incredibly important aspect of actually developing health systems.
Next question somewhere in the middle, please. Thank you.
Yeah, Claude Primes from the Oswaldo Cruz Foundation in Brazil. The outbreaks are more likely to occur in low and medium income countries, which often have an important shortage of health professionals and a very poor health infrastructure to treat the population. So, for instance, we know that in the sub-Saharan Africa, there's less than one doctor or one nurse per 1,000 people. My question would be is how can we increase this health workforce and improve the health systems in these regions in order to respond faster to an outbreak.
Madam President, is that Kerry?
Kerry, but I think I'll just react again to what Camilla has said, to look at the health systems. And we need to do the mapping, but definitely there is a need for capacity building. And we have, on the African continent, at a level of countries, to really look at the statistics, which of course, they are really, really crying out for numbers to be at par with what OECD countries have, the emerging countries have, and definitely in African continent, there is a need to really improve on the statistics. And it is very, very weak, and this is where, again, as you have rightly said, there is a role for CARI there to see to it that in terms of capacity building, we are responding to the numbers. But having said this, responding to the numbers is okay. Having the health system, accessing databases, you also need fully trained people to be able to actually convert whatever data there is into eventual information and into policy. So again, this is the whole landscape that needs to be done, and how do we bring this capacity, what tools do we bring, and how do we bring diaspora, how do we bring other talents to actually work with these professionals to bring them up to that level so that there is better preparedness eventually.
Great, thank you.
Okay. All the way in the left, I believe I see you, Rebecca. Do you have a person there? Please. Thank you. I guess not. No question? One more. I see one right there. Yeah, thank you. We'll come next to you. Yeah.
Hello, I'm Sandeep from SWAST. I just wanted to ask, from a pandemic perspective, what is the health system preparedness that is needed? So, from in terms of infrastructure, people, so what would be a good healthcare system to support it?
To support pandemic response?
Yes, to support pandemic.
Camilla, what do you think?
Where shall we start? Well, you need surveillance and good surveillance systems and exchange of information across borders and within countries that are efficient systems so that you can detect outbreaks at an early stage. That is perhaps the most important thing. So that also means you need transparency, you need strong organizations that are independent of governments and other interests, for example, commercial interests, so that they actually do report an outbreak or suspicion of an outbreak, and have the capacity and the tools to do so. So that's just one aspect of it. But of course, again, you need capacity in the healthcare system once the outbreak is there, and you need research and development and innovation as an integrated part of it, but that must be addressed at an international level, not only at national levels. That's just beginning. This is a long lecture to mention some aspects.
Leah, we can take one from that side. Yes, please.
Yes. I'm actually Wayne Curtis. I'm actually been spending 30 years training students to produce pharmaceuticals, and thanks to technology during this talk, I was talking to a lot of former students, and part of that discussion was, for instance, someone who directed world operations for Eli Lilly, and the thing that I haven't seen here is the concept of actually producing the vaccines and so forth. And I was wondering, there's some comment, I mean, we're talking about all of this, but some of the rate limiting steps is the actual then production rather than just simply the development of the science and so forth.
Penny, do you want to tell us, are you just going to be developing vaccines in Africa? Will there ever be actual production?
Production, yeah, absolutely. So when we talk about vaccine development, it actually includes 3 components, and that's the clinical trials, and that's what many people think of when they think of vaccine development. But there's also, of course, all the preclinical work that supports it, but there's also the regulatory strategy, and then probably, the key and one of the hardest things to do is what we call CMC, or bioprocess formulation manufacturing development for vaccines. And that really has to happen in concert with your preclinical and clinical development. That all goes together. And so at the Institute, we will have experts in production, if you will, that will be part of the Institute. In fact, we envision, heavily weighting that type of talent within the Institute so that we can understand early on, is this great new invention that's come into the Institute, can it be produced commercially? Is it going to be viable, and can we deliver it to the patients who need it, or to the individuals who need it? So that will very much be part of that development. The same like with CEPI and pandemic preparedness, that manufacturing development is occurring right in parallel. The vision there is to stockpile vaccines and at the phase 2 mark so that they would be ready for use in the event of an outbreak. Now, at the Institute, we will need, as we finish our translational development and get proof of concept in the target population, we will be partnering with other partners for that commercial manufacturing, if you will. That could include any number of partners. That could include our product development partners with low-income country manufacturers. That could include pharma, et cetera. But that will be part of the partnering process to make sure that vaccines is available to those in low-income countries who need it.
Madam President, on that question, I frequently get asked about local manufacturing. And it's interesting in the vaccine area, in modern vaccine area, because it wouldn't be a great creator of employment. It would certainly be high technology jobs, but not an avenue to sort of broad scale impact on the employment situation. How do you look at that in Africa, the sort of high tech local manufacturing versus more scalable other types of industrial activity that may be better job creators?
I'll perhaps answer the question just before this. I'll just make a remark of something. When we talk about drug development, increasingly we find that the focus now is going towards clinical trial in Africa for a reason that we need to have more adapted drugs, because many of the drugs which have been developed have been tested in the north, and they're not necessarily applicable, or the dosage may not be right for the people in the south. And this, of course, has opened up a kind of worms in terms of the efficacy of a lot of these drugs. So this is where we also need, again, to collaborate with institutions in the south so that we ensure that the drug which is being produced, and I'm novice in vaccine, I don't know about vaccine, but I presume there must be the same kind of dynamics in terms of testing the clinical trial for proper pharmacovigilance. And this is where H3 Africa has been instrumental in raising the awareness of pharmacogenetics. To come back again to the issue of manufacturing, we know that, we have one center in Mauritius that does formulation. We know that when you actually develop this, you look at the entire ecosystem for creation of that lab. So you actually bring on board the necessity to have trained people to address this. So this response speaks to the capacity building for training of necessary technicians and all the rest of it. So I think we need, again, if we are to shift the center of gravity for vaccine or any drug, some of it has to be done in these countries in the south, so that we create the awareness, we create also the necessary regulatory environment for this to happen. And if we can do this, we would have been shifting the center of gravity to Africa. So there is a space, and I think we need to explore that.
Great, thank you.
I think we're going to take one more question, and then we're going to wrap it up.
Final question.
One more question, I think, the last one. Thank you.
Thank you. I am Joris van der Put from the International Alliance for Biological Standardization, IEBS. And I just like to come back to the regulatory aspect, which is too often too much forgotten. I have two questions. First of all, in relation with new technologies, how to imply early on the regulators in the new process, because it's a quite long process before it gets adapted. And secondly, how to increase regulatory capacity in Africa, for example, and in particular. Thank you.
Penny, I know you've worked on some of those topics.
Yeah, exactly. So I think getting regulators, both in high-income countries and low-income countries, comfortable with new technologies is super important. and also getting their input early is very important. So that could be done, for example, in the Institute as new technologies come in. I envision engaging regulators, be they in the US, Canada, EU, Swissmedic, whoever, in a scientific advice type forum to get input on the development of those new technologies. But what we hope to do, and again, it's our vision, we aren't born yet, but where we really want to go is to actually take it a step farther and then collaborate with those regulators to then go to regulators in low-income countries. Can we work with ABRF? Can we work with the harmonization work that WHO and the Foundation is doing to introduce those new technologies, to introduce potential pathways for licensure to them early? So if we can start in the first couple of years that the Institute exists, then by the time something's ready for clinical trials in the target population in those countries in Africa and India, Southeast Asia, regulators will be familiar with the technology and will be ready to go. So I think it's a really important part of the strategy.
Camilla, you had a thought?
Just a quick addition to that, I think that it's important to develop regulatory systems across the globe, so not only in certain countries. But along with that, we need to develop much more efficient systems for doing health technology assessments. And that is, in a way, a research aspect, and to some extent, even an innovation aspect of what regulatory systems should do in the future.
And I think this is where Carrie again has a space. In this, we were looking at the preparedness. If you look at the matrix we were trying to develop, at least we'll know when we are operating in that space where the regulatory is strong and what needs to be done to raise the level, and in which area, if we're looking at non-communicable diseases, which country has the state of preparedness or which institution is there operating. So this is why I think we need to bring the conversation back again and relook at our matrix and see to it that we actually have this conversation around centers, regions, etc., that can have the absorptive capacity for new technologies as well. And the thinking process, before we actually introduce anything, we really need to look at the ecosystem and the landscape, whether there is absorptive capacity for these new technologies, and of course, at the same time, address the regulatory, which comes in much later.
Thank you, Madam President. And I thank the group over here for your attention and ask you to join me in thanking our panelists over here for their insightful answers to those questions. Thank you.
All right, so while our guest leaves the stage, few reminders, housekeeping. From here, we will move on to our scientific track sessions. Again, please check your agenda for specific track locations. At 5:30 p.m., we have a lineup of roundtable sessions. Please remember to see your flyers. We've got several of them running in parallel. At 6:30, there will be the second poster session. You still have, if you haven't done so, please cast your ballot. It's open until about 2 p.m. this afternoon. And then we will meet again for the evening event, another treat at the National Museum of American History. Shuttles will depart from the Marriott lobby at 7:30 p.m. Thank you very much and have a wonderful day. Thanks.